The BJS Prize Session, a highlight of the program, a very prestigious thing for our trainees and our presenters to win. The judges are in the audience. The format is 7 minutes and 3 minutes for question and answers. So our first presenter is Charlie West, who's presenting on behalf of the PelvEx Collaborative. Charlie, your time starts now.
And just for all the speakers, if you just point the clicker at the front of the room, it means that it will come through easy.
We'll give you another 15 seconds.
Morning, I'm Charlie West, a Southampton Colorectal Research Fellow, presenting part of my PhD, a consensus study on behalf of the PelvEx Collaborative. I've got no conflicts of interest. Many of you won't do pelvic exenteration surgery, and you've probably never heard of the empty pelvis syndrome, so should you listen? The majority of our patients at Southampton are referred from other hospitals, and we now know of all the readmissions for empty pelvis syndrome, a quarter of these are to these referring units. Furthermore, we now view this as a spectrum, and there may be some relevance for conventional TME, ELAPE, which happens at colorectal units across the UK. So to give some background on the pathophysiology, you have a pelvic exenteration with often maximal doses of radiotherapy. This creates a huge pelvic dead space in the bottom of the pelvis, which small bowel falls into. You get fluid accumulation and bacterial translocation across the small bowel into this space, causing chronic perineal sepsis, which in turn can cause intestinal failure and perineal wound failure, ultimately having a devastating impact on an often very vulnerable group of patients. And this isn't a new problem. It was first defined in 1993. However, since 2015, there's been a massive increase in this issue, possibly culminating with the incidence of high complexity exenteration becoming standard of care, whether this be exenteration that encompasses major resection of bone, aort as part of an exenteration, or ongovascular reconstruction for major sidewall resections. And although these advances have great oncological benefits, they do come at a cost, which patients also want the answers to. So this is one of our patients just describing some of the issues that she's had with the empty pelvis syndrome, and it has been devastating for her. There are many techniques that can be used to mitigate this issue, such as omentoplasty, mesh slings, or even breast implants seen here. And a systematic review was unable to determine any significant difference between these and was not able to highlight a single effective technique. And also in this field, in the pelvic exenteration field, lots of vague terms are used, like beyond TME, partial exenteration, modified exenteration. And these terms, they don't really mean anything precise. So what that means is that in the literature, you're ending up comparing patients that have actually had different magnitudes of surgery. And to put this to you pictorially, the patient on the left has had a conventional exenteration, while the patient on the right has had a high complexity exenteration. And you can just see from the photos, they're not going to have the same morbidity even before you start considering what method of reconstruction you're going to use. So our hypothesis is that there's heterogeneous outcome reporting, heterogeneous patients. We don't really know what the patient perspectives are of this issue, and this is leading to very varied clinical practice and research waste stagnating progress. And our objectives were therefore to define a minimum set of outcomes that should always be given when describing the empty pelvis using comic guidelines, and similarly to give a core descriptor set to address that patient heterogeneity. And lastly, core outcome sets are often limited, as you don't take that next step and define how something should be measured and diagnosed. So therefore, we also use COSMIN guidelines to take that next step to make it very black and white. And COSMIN guidelines also allow you to identify future research priorities, which we made use of. We were supported by the PelvEx Collaborative, giving us an international group of experts, and Bowel Research UK identified patients for us with lived experience of this issue. And we used a three-stage consensus method approach with long listing of statements, shortlisting, and confirming. Shortlisting was based on the systematic review and also engaging PelvEx and patient representatives. We also piloted the Delphi study with an international steering committee before wider dissemination. This left us with 70 long-listed statements. And then shortlisting was with 2 rounds of Delphi, and we gave the patient and surgeon voice equal weight with this by separating the analysis for these and reporting it separately with the histogram seen in blue and red here. We were left with 18 statements, but then before proceeding to consensus meetings, like a regular consensus study, we took the time to go through the COSMIN steps, and we considered conceptual considerations completed by what we'd done. We systematically looked for ways to measure the statements that we'd shortlisted, and we assessed these so that when we went to consensus meetings, we were able to present these questions to the PelvEx Collaborative audience. Meetings themselves were separated, with patient representatives happening online, supported by Bowel Research UK. And at PelvEx 2023, we used a modified nominal group technique to decide whether a core statement should be included in the final core data set. And if it was, we would then enact those COSMIN questions that we prepared. And if it wasn't, we then ignored the COSMIN work that we'd done and skipped it, just so that we could come away from this with everything we needed. And these are our results. So this slide shows the strength of experience and diversity within PelvEx, with over 1,000 years of clinical experience and participation from across 5 different continents. Similarly, we had an intercontinental group of patient representatives that have had a diverse method of reconstruction. And this left us with 7 measurable core outcomes. The first was an infected pelvic collection, which we said had to be diagnosed by a radiologist on CT. We had pelvic bowel obstruction diagnosed on CT with a pelvic transition point. An enteroperineal fistula, which was a binary outcome. A chronic perineal sinus, which could be a visceral or cutaneous wound that had to be draining for at least 6 months following surgery. Reintervention, coded using the Clavier-Lindo classification. Morbidity from reconstruction itself, such as an ischemic VRAM seen here. And quality of life. And this is one of those areas where there was no validated measure. So it's a future research priority, and you can see some of our early work on this at the meeting at poster 191. And we have an ongoing mixed method study with our patient co-investigator who was supposed to be speaking, but the video didn't work there. Then the 4 core descriptors. So magnitude of surgery using the indispensable pelvic exenteration lexicon, which addresses that apples and oranges problem by precisely defining what you do in each anatomical compartment. We think radiotherapy is hugely important, and therefore this should be measured simply in grays, cumulatively. Method of reconstruction needs to be reported, biological mesh, for example, seen here. And changes in volume of pelvic dead space. Again, there were no validated measures of this, and this is something we're working on to produce a volumetric definition for the empty pelvis syndrome, similar to what's currently in place for loss of domain in the context of massive ventral hernias. And we think most likely this will be done radiologically. So in terms of next step, we've actually already piloted the core data set, and we know it works. We presented these results last week at PelvEx 2024 in London, and we found actually that 1/3 of our patients suffer these complications. So for us, it's a hugely important issue. So just to wrap up, this is the first time the core outcome set and core descriptor set have both been combined with COSMIN guidelines to make a very shades of grey problem, black and white, and measurable. It confirms that the empty pelvis syndrome is an area of unmet need. And we know that patients are coming to DGHs with these issues, so this is something we feel the wider colorectal community should be aware of. I want to say thank you to PelvEx, my funders, particularly Sam from Bowel Research UK, and I'm happy to take any questions.
Excellent, Charlie. Thank you very much for a very clear and concise presentation. I have just to start off the questions, to remind everyone in the audience, please send through your questions on the app. And just to start off, Charlie, you mentioned the term high complexity exenteration. Perhaps people in the audience might not be as familiar with that. Could you just outline what you mean by that?
Yeah, so my understanding of that is NICE currently commissions central exenteration, which is just soft tissue exenteration, so removal of womb, bladder, rectum. However, when you start getting into the sidewall structures or getting into bone, we would then classify that as high complexity.
Excellent, and we hope that that's considered to correlate with increased morbidity.
So let me ask Charlie, now you've done this work, how has it changed the way you consent patients?
Well, as I pointed out, the quality of life is really important. We don't really know what the impact of this is on patients. My professor does now add this to his consent forms, but we're doing a qualitative work package, and we're finding some really interesting things, such as phantom rectum sensations, phantom bladder sensations that can have a really devastating impact on patients, although that does need a bit more unpicking. But I think in the exenterative literature, qualitative work is really required, and we're hoping to do that. And there's a poster, as I pointed out, that you can see some of those early results.
Fantastic. Well, thank you very much, Charlie. I think we'll move on to the next speaker now. I'm delighted to welcome Yusuf Hassan to the podium to discuss the medium to long-term outcome from ilioanal pouch surgery.
Good Good morning, everyone, and it's a pleasure to be joining you all, coming all the way from Melbourne, Australia. I'd like you all to meet Sarah Matthews, a 29-year-old female who's been suffering with chronically active ulcerative colitis, despite maximal medical therapy. And she's been referred to you to discuss surgical options. She doesn't want a stoma. As an experienced colorectal surgeon, you offer her the gold standard continence-sparing surgery, an ilioanal pouch procedure, in this case a J pouch, to which Sarah is very enthusiastic and launches into a barrage of questions, keen to control her symptoms and regain her life. Is this surgery safe? How common are complications? Will I still need medication lifelong? Will my life be better? You try your best to answer her confidently, but deep down wish you had more evidence. This uncertainty surrounding medium to long-term outcomes of ilioanal pouch procedures in IBD patients sparked my review of the topic under the supervision of Associate Professor Emily Wright and the support of the IBD unit at St Vincent Hospital in Melbourne, Australia. We have no conflicts of interest to disclose. So the current understanding of ilioanal pouch procedures is that they're the gold standard continence-sparing surgery for medically refractory ulcerative colitis, but are rarely indicated in Crohn's disease due to the risk of recurrent small bowel inflammation. But real uncertainty surrounds the incidence of medium to long-term complications and the risk factors associated with those complications, alongside functional and quality of life outcomes. And that's where our review comes in. And our primary aim was to report a long list of incidences of all those complications on screen, but with a particular focus on chronic pouchitis and pouch failure, and a secondary aim looking at risk factors associated with those two troublesome complications. 2 online databases were searched over the past 10 years with adult IBD patients with adequate follow-up who had undergone a pouch procedure included, whereas studies focused solely on acute surgical outcomes or lacked complication definitions, or particularly a distinction between acute and chronic pouchitis, were excluded. 1,094 studies were screened and ultimately 49 were included. Of the 49, a median cohort size of 282 patients across 13 countries with substantial follow-up were found. And I won't bore you with a long list of numbers, but I'll be focusing particularly on the chronic pouchitis and pouch failure, as well as risk factors along the clinical journey for those 2 complications. Chronic pouchitis, as we defined as an episode of inflammatory symptoms lasting greater than 4 weeks, had a median incidence of 17.1% across 12 studies, and this was much lower than a other review that reported this to be around a third of patients. Whilst pouch failure, defined as the need for permanent ileostomy with or without pouch excision, had a median incidence of 6.7% across 15 studies. With regards to medications, ongoing use of medications post-operatively affected a majority of patients, particularly motility agents to combat diarrhea. And on that note, frequent daytime and nocturnal bowel actions alongside defecatory urgency still affected a majority of patients. But despite all this, quality of life post-ilioanal pouch procedure remained very, very high amongst our patients, where patient satisfaction was greater than 90% in 4 studies, where a majority of patients would say they'd undergo a pouch procedure again, with many wishing they had it done earlier. Now, looking at the risk factors along the clinical journey for pouch failure. Preoperatively, certain hematological markers, namely low albumin, was associated with development of pouch failure down the line. Perioperative complications and post-operative use of biologics, pouch-associated hospitalization and pouch fistula were all associated with pouch failure down the line. And as is well known, a final diagnosis of Crohn's disease was also associated with pouch failure. Looking at chronic pouchitis, preoperative severe disease phenotype was associated with a development of chronic pouchitis down the line, whereas along the rest of the clinical journey, no other risk factors were associated multiple times. Our review did come with its limitations in the fact that it was retrospective in nature, had a single reviewer, and lacked quality assessment of studies, and the sheer broad nature of the review lacked in our ability to have specific analysis of certain complications. And within the included studies, vast heterogeneity did exist in terms of disease phenotype, surgical technique, and underlying type of IBD. So that brings us back to Sarah and what we'd tell her. We'd say that complications are common, yet patient satisfaction post-pouch procedure remains very high. And more broadly in terms of the wider IBD and pouch space, in that we believe that this review helps equip us all with better information to counsel our patients preoperatively, as well as contributes to steps to more personalised IBD care. Thank you all very much for listening, and I'm happy to answer some questions.
Thank you, Youssef. Huge amounts of work go into these systematic reviews, and huge amounts of data comes out of it. I guess perhaps, can you summarise how this has changed practice for you locally? And we know some of these risk factors. How do we personalise that to the shared decision-making that goes on with individual patients for what is a lifestyle operation in many ways?
Yes, definitely. And I know it was touched on in the earlier session about the importance of shared decision-making with such a surgery. I think ultimately, given it was a very broad review, it's very difficult to then step into specific answers to patients based on this one review. I think the one thing it's changed for me is to at least put some discrete numbers in terms of what chronic pouchitis versus a simple episode of acute pouchitis that would resolve with antibiotics. I think the pouch failure numbers are also quite reassuring, but also it allows us to have that conversation with a patient with whether it's having a pouch or having a stoma. We have now some numbers to back up the having a pouch, but also I think it also propels us to look further into those risk factors with more targeted, narrow-based studies, given the heterogeneity at play.
Thank you. A couple of questions coming into the audience. Please do keep them coming in. First of all, do you think the high satisfaction rates in the pouch patient really reflects the alternative in that they don't want a stoma?
That's a great question, and I think that ultimately a big part of quality of life assessments can be rather subjective in nature, in the fact that we didn't use validated studies across the board. And I think patient expectations is a very, very big part of it as well. And I think that also contributes to those discussions preoperatively, in that if you're having those discussions and laying it all out on the table in terms of patient expectations and seeing where the patient is coming from, that could obviously guide them one way to another and further inform them of what a stoma actually looks like and what life looks like, and the quality of life they can have with a stoma could potentially be affecting that as well.
Thank you. And two sort of further questions which are interlinked. How do you think that the readers and those in the audience should sort of caveat the conclusions given the lack of quality assessment of the studies in the review, and did you look for outcome reporting bias?
Yeah, no, great point. I think overall it gives us a better picture of the numbers, but I definitely believe that more targeted reviews are required. Going through the research of this, there was many studies across many different outcomes, but I'd love to narrow the focus. So I'd say take it with a grain of salt, and then also propels us to further look at specifically chronic pouchitis with the clear definitions that we try to define at play here, and similarly in terms of risk factors, prospective studies with biobanking would really be the gold standard to guide our knowledge.
Brilliant. Thank you very much indeed, Youssef. Thank you.
Thank you very much.
So for our next speaker, we're combining cancer, IBD, and throwing a bit of endoscopy in. Katie Siggins, thank you.
Good morning, my name is Katie Siggins. I'm an endoscopy research fellow in Portsmouth Hospital. Thank you for the opportunity to present our work about long-term outcomes of endoscopic resection in IBD this morning. So I have personally got nothing to declare. So over the last half a century, there's been big paradigm shifts in the management of dysplasia in patients with IBD. So since flexible endoscopy was introduced in the 1960s, there was for a long time this notion that a lot of dysplasia was invisible, and this concept of field change. So patients were typically offered a colectomy when they developed dysplasia. We then in the 1990s had the introduction of biologics, which improved disease control and perhaps has contributed to the reduction in development of dysplasia. And then we've had advances in endoscopic techniques, such as the introduction of high-definition endoscopy and narrowband imaging from Olympus in the late 90s. And then in 2004, Matt Rutter published this paper saying that actually most dysplasia is visible now that we've got these better quality endoscopes. Following on from that, in Japan in the late 2000s, endoscopic submucosal dissection was pioneered for the use in early gastric cancer. And then this is transferred over into patients that have got inflammatory bowel disease, that we can start thinking about organ preservation for them. But what we don't know about from all of the literature that's mainly focused on the technical feasibility of endoscopic resection is what's the long-term outcomes in these patients. So there has been some work done from St. Mark's looking at the risk of low-grade dysplasia turning into advanced neoplasia or cancer over time, but there's not been very much focusing on the longer-term outcomes. So this data is from 3 centres in the United Kingdom, so Portsmouth Hospital, King's College Hospital and St. Mark's. Each of them are high-volume advanced endoscopic centres, and each has individually published their personal outcomes for endoscopic resection and IBD. So this was looking at the longer-term data in this cohort of patients. So what we planned to look at in this study was all endoscopic resections from 2008 that had a minimum of 12 months follow-up, and that included all endoscopic resection modalities, so endoscopic submucosal dissection, hybrid ESD, so some people call it knife-assisted resection, and EMR. And we looked at the need for surgery and why patients had surgery, who developed metachronous lesions and how they were managed, who developed recurrence and how it was managed, mortality, and looking at any high-risk groups. So you can see here, this is a little video demonstrating ESD. So this is a rectal lesion that's about 50 millimeters, that's very subtle on white light, more obvious on image enhancement and on chromoendoscopy. And the lesion is marked, dissected, and then it's been removed. That's a good outcome for the patient. It was all traditional serrated adenoma with low-grade dysplasia. So in terms of our study, we had 118 patients that underwent endoscopic resection, but follow-up data was only available in 97 patients. And we had a median overall follow-up of 44.5 months, and that ranged up to 14 years. In patients that had surveillance, the follow-up was slightly longer at 46 months, and you can see some patient demographics. The median age was 65. There was a majority of patients had ulcerative colitis, and we had 16 patients that had PSC, which is obviously typically recognized as a risk factor in dysplasia. Looking at our lesion characteristics, the median size was 30 millimeters, so these are all considered large lesions, and there was a slight majority of non-polypoids, so Paris 2A, 2B, 2C, and there's an even distribution throughout the colon with the rectum and left and right colon. As you'd expect from the centres doing the procedures, the majority were removed via ESD, and we had 68 of them being en bloc, and that's a breakdown of the histology there. So this is a summary of our results. It's quite a small diagram, so we'll focus on each bit in more detail. So first of all, looking at the patients that went on to have surgery. So this got defined into 2 main blocks. So we had patients that had surgery directly as a result from their endoscopic resection outcome. So that was this group, and we had a group of patients that had it in the longer term. So if we list all of the patients, there were 16 in total. This is the group that 8 of them had them following the endoscopic resection. So there was 2 that had surgery for a delayed perforation, and there was 5 that had went on to have surgery for an R1 resection following an endoscopic resection of an adenocarcinoma. Looking at the longer term outcomes, this ranged anywhere from 7 months up to 12 years. And looking at things that are very relevant here, as I touched on already, there was the R1 resections, but then in total 4 patients ended up developing metachronous adenocarcinoma, which was anywhere between 3 and 12 years after their original endoscopic resection. Next, if we look at the patients that entered endoscopic surveillance, we had 7 patients that developed recurrence. I won't go into this in too much detail because this is typically reported in the technical feasibility papers as it's more of a short-term outcome. But all bar one patient had successful management endoscopically, and one patient had an ESD and then had a second recurrence and then ended up being referred for surgery. But we have got various different techniques for endoscopic management available to us when recurrence have developed, so either further ESD or things like endoscopic full thickness resection, as is demonstrated in this picture, or some kit such as Endorota. Next, we looked at who developed metachronous lesions. There was 26 in total, and as I said, 4 of those were adenocarcinoma that all went on to have surgery. But the majority of them were managed endoscopically as well, so there were 6 ESD, 2 CAR, and 8 EMR from that. And again, the histology from this was mostly low-grade dysplasia, and it is quite a high number of patients that have primary sclerosing cholangitis, as you'd expect, and again, with pancolitis as well. Finally, we looked at mortality from this cohort of patients. So in total, 15 patients out of the 96 patients died during this study period. One case was related to their IBD that had a previous rectal cancer that had been operated on many years before, and they ended up with metastatic disease from that, but all other deaths were for unrelated causes. And when we looked at why this mortality rate seems quite high, it may be that this is a comorbid population. The median age in this group was 72 compared to our median age of 65 in the overall group. So in conclusion, endoscopic resection is feasible and curative in carefully selected patients, but they do require meticulous long-term surveillance due to the high risk of metachronous lesions. So if you have a patient that wants to have endoscopic resection, they need to be aware that they have to turn up for their endoscopies, they have to be willing to work together to make sure that we keep an eye on their colon. And a relatively high proportion went on to have surgery, and again, a relatively high proportion ended up dying within 5 years of their procedure. We feel that en bloc resection, as a lot of guidelines suggest, is preferred, and so therefore we should consider referral to tertiary units. And I think this is useful information for counselling patients that have got IBD with visible neoplasia. Thanks.
Thank you very much, Katie. I'm just going to start off with a question while they come in from the audience. 4 R1s for adenocarcinoma, it's about 4%. What do you think about the acceptability of that, and could they be predicted, and what were their outcomes?
What I need to look at is how many of those pre-endoscopic resection we knew were cancer versus unexpected cancers in the resection specimen. I think that from our experience in our units, if we know in advance that it's cancer, most patients end up having surgery. So you could say that this could be a guide to needing to have surgeries to give you accurate staging, where if you've only ever had a biopsy that's shown low grade or high grade. But I think that you're right, it is a relatively high R1 rate, but they all went on to have surgery and had good outcomes from their surgery.
Lovely talk, Katie, thank you. Can I ask about management of perforation in these patients? Because obviously the more complex the polypectomy, the more likely you are to have a perforation. And given we know that we can manage routine perforations conservatively in a well-prepared bowel, in a relatively unsymptomatic patient, how are you counselling these patients? Because some of them will be having EMR, ESD because they're not fit enough for surgery. And because of the cancer component of this, is that an indication for surgery early, because effectively you've perforated the cancer? So what is the management strategy for perforation in these patients?
So it's a very important question. So we find that perforation intraprocedurally can generally be managed endoscopically because you would usually have a well-prepared bowel. From our experience, if you have poor preparation, you'd be more likely to abandon the procedure. But in the context of a well-prepared bowel and you recognise a perforation intraprocedurally, then generally you can manage it endoscopically by clipping. And I don't think any of our patient cohort ended up having surgery as a result of an intraprocedural perforation. It's the delayed perforations that almost all require surgery. With your question about the risk of seeding, again, I think there's very little evidence actually about the risk of seeding after endoscopic resection. So there was a paper from Japan about seeding after early gastric cancers, and they showed that actually there was no increased risk from endoscopic resection from early gastric cancer, but in the colon there's not that much. But I think it's all about a good assessment beforehand and being able to predict, is this a cancer? And then if you are struggling and you think there's a high risk of perforation, backing off at that point so that you don't end up putting the patient at more risk if that occurs.
Thank you. Thank you very much, Katie. There were lots of questions there, but I'm sure people can find you over coffee later. For the sake of time, we'll move on, and it gives me great pleasure to welcome Jordan is going to talk about personalised 3D imaging in pelvic exenteration patients.
Thank you for the opportunity to present our work looking at the role of personalised 3D models in patient decision-making in complex cancer, which we undertook as part of my PhD at St Mark's Hospital. So it's often said a picture speaks 1,000 words, and I think that's particularly apt when we think about the way we communicate with patients undergoing surgery. We want shared decision-making, and I think the way we present data, the way we visualize it, is fundamental to that. Oftentimes, many of us will draw in the notes, use visual aids. 3D models represent an advancement on this, perhaps. So if we think about some of the challenges that patients undergoing exenteration face, you're dealing with really complex anatomy. It's high morbidity surgery with life-altering consequences, and patients are often faced with a difficult decision of balancing short-term and medium-term quality of life impact with the potential of extending life. Our hypothesis was that 3D models are intuitively better, easier to understand, and can facilitate patient decision-making. Following some initial pilot work in which we developed the model process, we conducted a mixed methods randomized study in which patients were randomized to the intervention group and the standard consent process, which typically consists of serial appointments for around 40 minutes in which the patient's seen by the surgeon, consultant radiologist, and CNS nurse. The primary outcome measure for this, objectively, was the decisional conflict score, which was administered pre- and post-consultation, along with a patient knowledge score, which we devised for the study, in which we compared the degree of agreement between what the patients thought they were having versus what we thought we were doing, along with subjective model feedback. And in order to facilitate a more nuanced understanding about how these models may have influenced decision-making and how the patients experienced them, we conducted semi-structured interviews which were transcribed on Zoom and subsequently thematically analysed during dual rater coding. Just briefly, I want to provide an overview of how these models are actually produced. It starts with high-quality imaging. We then subsequently perform something called segmentation, in which we essentially take the scan and label all the anatomical structures of interest, extract a 3D polygon mesh, which undergoes quite extensive processing in a similar means in which we produce computer game assets or visual effects. The end result is this, something which I've characterized broadly as stylized realism. These models are interactive, they can be used on even an NHS computer, and were devised with the patients in focus groups in order to optimize them for their kind of patient understanding and appearance. If you scan the QR code, you can look at some of these models online. So we assessed 64 patients for eligibility, and after exclusions, we had 29 in the 3D group and 22 in the control group. The demographics were largely matched, save for the operative complexity, which was more in the 3D group as evidenced by the pelvic exent lexicon score, and also the number of structures which were going to be resected, which was a median of 6 in the 3D group and 4.5 in the standard. The decisional conflict score was significantly reduced in each group, although the magnitude of this change was larger in the 3D group. Both groups had a median post score of 24, which corresponds to a level where patients are likely to make a decision. The overall subjective feedback to the models was overwhelmingly positive. Most patients agree that it improves their understanding. To a slightly lesser degree, facilitates their decision-making, and crucially, it was better than just looking at the radiological images, perhaps unsurprisingly. The consensus between the patient and the surgeons with respect to what anatomical structures are being resected was high in both groups with no statistical difference. However, when we looked at the functional outcomes, which looked at post-op bowel function, mobility, urinary function, and sexual function, this was significantly higher in the 3D group. I think the really interesting data was actually when we spoke to these patients afterwards, and we identified the following interrelated themes. Overwhelmingly, I think understanding underpins the benefits of these models. Every patient you speak to says that this clarifies what their disease is, the extent of their tumor, and what they're going to have done. But more than that, I think it helps them, or they report it helps them with the emotional processing of this disease. A lot of patients talked about the emotional release of actually seeing their tumor. I suppose cancer is this amorphous threat. Well, when you can actually see something, this seems like something that they can get their head round and maybe beat. This really facilitates communication. So the patients are taking these models and showing their family. They can share it with their loved ones. I think it reduces the inherent power imbalance between surgical team and the patient, because fundamentally we have a lot of knowledge and they have very little. The personalization, I think, is critically important to the benefit of these models. So patients talked about how this instilled trust in the surgical team because we knew what we were dealing with. And I think it has a unique impact on the understanding by being able to actually see your disease. The impact on decision making is probably complex. I think there's certain scenarios where it's probably more critically important, but a lot of the patients talked about how it didn't necessarily change their decision, but fundamentally made it easier to make. In conclusion, these models are a useful adjunct to the consultation process in exenteration surgery. And I just wanted to show you a little bit about the work we've done after this project was completed. So the model production time is a big problem. So we've automated this now using Python scripting. And we've also experimented with novel interface methods. So we've had a play and have started exploring the possibility of integrating these models into augmented reality using the Apple Vision Pro headset. And finally, we've developed a provisional convolutional neural network to help automate the segmentation process to speed up model production. We've had some limited success with some initial feasibility work and are looking to expand this with higher computational resources. Thank you.
Thank you, Jordan. You know you're getting old when you sit there thinking, God, PowerPoint's moved on. And there are patients who sometimes don't want to know. And so have you come across those? And is this a mechanism of engaging them, or do they still not want to know?
We didn't encounter that in the actual study. I suppose the patients are probably in a slightly niche subgroup in that they've already been usually seen at a previous hospital. They've previously had their disease discussed. So in that subgroup, everyone was kind of very keen to see their disease and were glad to see that, or at least interested to see their model. I suppose, yeah, there will be a degree to which some patients don't want to know, and in which case that's absolutely fine. We don't need to ramrod it down them. It's there for them if they need it. But in the group we looked at, I didn't find that.
Thank you, Jordan. A couple of questions coming in on the link, sort of two that are interlinked. Could you not get the same outcomes using a standardized 3D model? And what about the financial cost of both time and processing? So, with respect to the personalization aspect, I think when I spoke to every patient, I asked them, you know, is it important that this is personal to you? And what about if we just used a generic model and maybe showed a blob? And overwhelmingly, every single person you speak to says, no, I want my disease. And I also think that there's certain things whereby, you know, I'll give an example. So there was a lady who was fairly young, had had one child, but was looking at a full pelvic exenteration, including a threatened ovary. She was really reticent to go ahead with that operation, or really had to think about it. Looking at the model helped her come to the conclusion that actually this needed to be done. So I think there are specific benefits. With respect to cost, so, I mean, this study was largely, all the reconstructions were done by myself, so the cost was actually free for this.
But if you're looking at commercial companies, you're looking at a model which would be in the region of £200 to £300 and wouldn't look quite as aesthetically pleasing as that. But if you view it in a wider context of this model is not just for patient education, you can use it for planning, you can use it for surgical education, you can use it for intraoperative navigation. I think the value proposition maybe improves when you view it as a wider product rather than just as an isolated patient education tool.
Thank you very much, Jordan.
I think we'll leave it there, Jordan. Thanks very much indeed.
And we will move on to our last talk of this session, which is Charlene, who's going to talk about rectovaginal fistula and move quite far away from all the other cancer talks. So we're delighted to hear this talk.
Good morning to the audience, and firstly, thank you to St. Mark's Hospital and to ACPGBI for giving me this opportunity and for inviting me to give this talk on a very important subject matter on the development of a rectovaginal fistula core outcome set. I have no disclosures. So what do we know? We know that rectovaginal fistula is a devastating condition, profoundly impacting quality of life. It's notoriously difficult to cure, it's too rare to gain expertise, and there are various different types of treatment options with different success rates. As we know, a rectovaginal fistula results from the abnormal connection between the posterior wall of the vagina and the anterior wall of the rectum. This area is separated by a thin collagenous membrane called the rectovaginal septum. During an examination under anesthesia, sometimes it can be quite obvious to detect a rectovaginal fistula, and in other circumstances, they can be very small and discrete. Irrespective of the site and size of the rectovaginal fistula, patients describe a miserable, difficult journey, such as the uncontrollable passage of stool or flatus through the vagina, painful sex, and let's not forget the profound psychological impairment, body disfigurement, social isolation, and depression. Of course, there are various different types of causes of rectovaginal fistulae, the commonest cause being obstetric injury, which accounts for 88% of it, Crohn's disease, rarer causes such as radiotherapy, and iatrogenic injury. Hippocrates described the first type of management for rectovaginal fistulae with cetons, and since then there's been a plethora of various different types of techniques, namely Marsh's flap, omentoplasty, or Turnbull cutate procedure. So what is the current problem? Well, of course, there are different types of treatment techniques, but there is a lack of standardized outcomes, which means it's difficult to compare and analyze studies. And this opens the way for bias reporting. And more importantly, it lacks patient involvement. So we saw a desperate need to develop a rectovaginal fistula core outcome set with use of the COMET guidelines and the core outcome set measurement of effectiveness trial. And it states that this is an agreed standardized set of outcomes that should be measured and reported as a minimum in all types of research to do with rectovaginal fistulae. We need it because currently there are various different types of surgeons doing different types of things, and we need it for assessment of an effectiveness of different treatments. We did this through 3 stages. The first stage was generating the outcomes, looking at what is out there. We did it through exploratory interviews, discussing qualitative interviews through the different etiological subsets until we reached a point of saturation. We then explored the systematic reviews and combined the outcomes and had a total of 130 outcomes on our long list. Some of the examples include pain, rectal stricture, and fistula recurrence, which was extracted from the systematic review. Coming from the interviews, discharge such as flatus or pain such as vaginal discomfort. We presented these outcomes to our study management group, which include patients and a multidisciplinary team. And in my view, the patients form the most important members of the study management group. We had surgeons, gastroenterologists, a radiologist, obstetrician and gynecologists, a midwife, and an IBD specialist nurse. We came up with a total of 11 outcomes, 11 domains and 40 outcomes, such as vaginal discharge, pain, the overall well-being, other symptoms such as urinary tract infections. It also included problems with anal incontinence, fistula tract healing, the psychological impact, quality of life, the impact of sex, and also negative impact, and also childbearing, which also include the physiological and psychological aspect. We invited stakeholders to go online and rate these outcomes, what they deemed to be important, what was critical and crucial to them, by rating it on a Likert scale on a COMET-supported Delphi online survey. Our stakeholders were mainly populated within the UK, but we also extended a little bit overseas to invite the renowned experts within this field, and we are very grateful to the renowned stakeholders who took place in this study. For the first round, there were a total of 128 participants, namely patients, surgeons and radiologists, gynecologists, obstetricians, gastroenterologists, and IBD nurses. We had a slight attrition rate for the second round. And then there was round 2, and this provided the opportunity for stakeholders to go online, rate the outcomes, but also have the opportunity to see how the other stakeholders performed in the previous round, have a look at their previous score, and also decide whether or not they wanted to change their rating. So we analysed this to decide whether the outcomes remained in for consensus in or out, or there was no consensus. It also provided this opportunity for stakeholders to provide new outcomes too. The overall was that there was a total of 40 outcomes, and this also went into round 2. Additional outcomes included sleep disturbances, aesthetic appearance of the anus and the vagina. We reviewed this and presented it to our consensus meeting, and there was a total of 28 outcomes. When the stakeholders determined whether an outcome should remain, they had to ask the question, what are the most important ways of measuring success? Will it actually change as a result of treatment? Is it the most important outcome, or are there outcomes that perhaps could be combined? We provided an application tool called Pool Everywhere, which would allow the stakeholders to rate the outcomes to decide whether they should be included or excluded in the study. So we had 7 final core outcome sets, namely the volume and nature of the vaginal discharge, clinical fistula healing, the global assessment of continence, including the impact on social life, complications following surgery, psychological and physiological impact on childbearing, global assessment on the impact of sex. This included the overall satisfaction with sex, the impact on sexual activity, such as sexual function and libido, pain and physical impact on vaginal intercourse, and then the global assessment of quality of life, such as well-being, impact on work and career, global measure of quality of life, impact on physical activity and relationships. So in summary, we devised a core outcome set which strongly involved patient involvement. We had 7 of them. It includes the main outcomes, but also includes commonly or less commonly reported ones. This was a holistic approach to defining the treatment of success. I'd like to take this opportunity to thank all these people who helped with this huge amount of work, and also to thank my fantastic supervisors, Mr. Phil Tozer, Professor Elsa Hart, and Ms. Caroline Vasey. In particular, to thank you to Mr. Phil Tozer for giving me this platform to do this important work and for believing in me. Thank you to the audience.
Great work, thank you, for what is a very distressing and debilitating condition and often overlooked. I suppose the success of this core outcomes set will be measured by whether it gets incorporated in research studies. And are you aware of any ongoing or any planned studies where your core outcome set will be utilised now?
Currently, there aren't any current ongoing ones, but in terms of what's important is how we're going to use, what sort of tools we'll use to measure the core outcome set. We have some fellows at the moment who are looking at reporting types of measurement tools for that.
Excellent. One of the questions that's come in is really how this might differ in terms of women who are pre-menopausal and post-menopausal. Have you seen any change between those two, or have you looked at the sort of case mix of patients involved?
In terms of whether they think different types of outcomes in those group of patients. Yeah. So interestingly, with our patients, if they're pre-menopausal, so a lot of their outcomes with treatment would determine whether or not they would have the ability to be fertile or have children. So that often was an important outcome for them. Is my operation going to change my ability to childbear? For the postmenopausal women, yes, of course, there may be some differences in outcomes with regard to that, in that case mix of patients. They would determine things like the psychological impact of living with this problem. Some of the postmenopausal women may not have had the opportunity to have children because they've had the condition for many years and wish that those sort of things would have been addressed.
Thank you very much. I think that's us out of time. I'm very grateful for all the speakers.